my topic is immunotherapy in OSSN. So a typical OSSN looks like this. So it is a limbal nodule with an interpalpebral location with intrinsic vascularity, surface keratin feeder vessels, and a corneal involvement. So having understood that, in the next few minutes, I will be taking you through the 10 key aspects of immunotherapy in OSSN. So the first description of use of interferon in OSSN was in the year 1994 by Maskin et al. They used topical interferon successfully in a case of conjunctival intraepithelial neoplasia. So what are interferons? Interferons are a group of glycoproteins produced by leukocytes which have anti-proliferative, antiviral, cytotoxic, anti-angiogenic, and immunomodulatory effects. So what are the advantages over surgical excision, which Anirban just now described? So the advantages are reduced risk of limbal stem cell deficiency. The side effects of surgery, which can happen like pseudopterygium formation, corneal opacity, are not there here. Treatment of microscopic disease possible, and I don't know what, I think this is Anirban's timer. Okay, so treatment of microscopic disease and reduce chances of recurrences theoretically, but it also has certain disadvantages, like it needs to be compounded freshly, it needs refrigeration, it requires multiple follow-up visits from the patient, and long-term compliance of the patient is extremely important when you start a patient on immunotherapy. So although nowadays many of us use immunotherapy as the primary treatment modality in the majority of our OSSN patients, there are 3 indications where it has definite advantage over surgery. So I will be listing them one by one. So what do I mean by immunoreduction? Immunoreduction is to reduce the tumor size to facilitate surgical excision. So this is for extensive or diffuse OSSNs with basal diameter more than 15 millimeter or more than 6 clock hours of limbal involvement.
Ma'am, please on your video.
My video is not on, but my
no,
video, here it is showing as switched on. I don't know, but the slides are visible, right?
Yes, we can see the slides. We can see you also.
Yeah, so it's switched on here.
Yes, so, ma'am. So now it's on.
So immunotherapy is sole treatment where we use interferon as a sole treatment for tumor regression, majorly in cases of predominantly corneal OSSN, like you see in this patient, a predominantly corneal OSSN completely regressing on interferon therapy. For smaller conjunctival or conjunctivo corneal OSSN, it can be used. For recurrent tumors, it can be used. So in immunoprevention, to prevent tumor recurrence, like what Anirban mentioned, like we have a protocol-based immunotherapy post-surgical excision. Whenever the surgical margins are positive, we use interferon for a duration of 3 months to prevent tumor recurrence. So the dosage varies from institute to institute. It ranges from 1 million international unit to 10 million international unit. This is what we are using at our institute right now. For topical, we use a dose of 1 million international unit per ml, 1 drop 4 times daily. So it is continued at least 3 months beyond the clinical resolution of the tumor. For subconjunctival injection, it comes as a pre-filled syringe. The entire pre-filled syringe is injected subconjunctivally. So the advantage of injection over drops are ensured patient compliance, quicker resolution, no compounding is required, and at times insurance coverage. So I will be taking you through this video where I show you how to prepare topical interferon eye drop. So on the aseptic precautions, we prepared this. So this is the pre-filled syringe of 5 million international unit. I'm emptying it in a sterile vial. I'm taking distilled water, 4 ml. which is again being emptied into the same vial. So here, patients in private practice, they also use the lubricants which are available. In the lubricant vial only they prepare it. So we hand this over to the patient with the date marked on it in a thermocol vial, placing ice packs there so that the temperature is maintained. And we instruct the patient to keep them in the door of the refrigerator, and monthly they come for the medication. So next, moving on to the injection technique for interferon. How do we inject? So this is done under topical anesthesia. A drop of proparacaine is being instilled. You can see the lesion there. So the pre-filled syringe is being injected subconjunctivally without touching the tumor. And you can see this bleb nicely raising all around. We need to take care that we do not go through a vessel, then there will be subconjunctival hemorrhage in the post-op period. So the cost is, we are very fortunate that way, that the cost is, it is very cheap in India compared to the West. Each syringe costs us around 800 rupees, and the average cost for 6 cycles is around 9,700. An additional cost of 800 will be there for each injection that we give. So it is very well tolerated in our patients. There can be mild side effects like irritation and stinging sensation, some conjunctival hyperemia or follicular conjunctivitis or SPKs. Systemic symptoms like flu-like symptoms, fever, myalgia can happen with injections. The 8th pearl here is long-term follow-up is very important in all these patients. While on treatment, every monthly they need to come to us. Post-resolution also they need to be on a strict follow-up regimen. What we do here is 3 monthly for a year, 4 monthly second year, 6 monthly third year, and yearly at least for a duration of 5 years. So a literature review shows that the response rate is very good, 80 to 100% with immunotherapy, the mean resolution time being 4 months, and the recurrence rate is around 8%. As you can see in this patient, it's a one-eyed patient where it has resolved completely only on 3 cycles of interferon therapy. So the 10th pearl is very important when not to consider immunotherapy. Whenever the diagnosis is in doubt, best is to perform incision biopsy, establish your diagnosis, and then start on immunotherapy. When the depth is in doubt, or it is a T3 stage tumor, that is, there is involvement of the adjacent structures, intraocular, cornea, fornix, tarsus, punctum, lid. When any of the adjacent structures are involved, we cannot give immunotherapy. Patient compliance is extremely important for starting a patient on immunotherapy. So we need to talk to the patient and clearly explain to them the need for long-term follow-up. And we don't give interferon routinely post-surgery. We only give when it is indicated, when the margins are positive. So with this, as I'm nearing to the end of my presentation, the points to retain from this presentation are the interferon are glycoproteins with anti-neoplastic properties. The absolute indications of interferon over surgery are immunotherapy in corneal OSSNs, immunoreduction in diffuse large OSSNs, and immunoprevention when the margins are positive post-excision biopsy. The dosage varies, topical 1 million international unit and subconjunctival 5 million international unit is what we are using. We give it at least for 3 months after complete tumor regression to take care of the microscopic residues. Long-term follow-up post-resolution is of utmost importance. The advantages of medical therapy include ability to treat the entire ocular surface and the potential to avoid stem cell deficiency associated with extensive surgical excisions. The average time for clinical resolution is 4 months. Thank you everyone for patient listening. Any query, you can mail me on this ID or you can WhatsApp me.